Today's conversation is one that feels deeply personal to me. We're going to talk about nursing and not the polished version, not the scripted version, not the version that fits into policies, protocols, or job descriptions. We are going to talk about the real heart of nursing, the patients you never forget, the moments that make you laugh, the ones that break you, the courage that it takes to speak up, and the weight nurses carry quietly, the kind of leadership that can shape another nurse's life without that leader ever realizing it. My guest today is the author of The Heart Behind the Badge, a memoir reflecting on 40 years of nursing, healing, courage, humor, advocacy, leadership, and the humanity at the bedside. But for me, this is not just an interview with an author. This is a full circle moment. Before we even get into the book and I introduce you to my guest, Dr. Lisa Caplan, I want to start personally with what you meant to me. When I was working as a PCT in a level 1 trauma center while going through nursing school, it was not an easy experience for me or a season. I spent about 2 years there. I was older. I was in my late 30s. Trying to find my place, and I experienced many cliques and unkindness that unfortunately do exist in nursing. But you were different. You were smart, you were kind, strong, and you always treated me with respect. You probably have no idea the impact you had on me. Oh, it makes me tear up. Today's episode of Nurses Out Loud is sponsored by West Cocoa Pharmacy and Compounding in Cocoa, Florida. They partner with licensed providers to compound ivermectin and other repurposed drugs, plus integrative protocols for people working with their oncology team, along with low-dose naltrexone, methylene blue, bioidentical hormone replacement, and men's health formulas. And my favorite part is you can speak to Nurse Donna for free. Learn more at cocopharmacy.com. COCOA pharmacy.com. This is educational only, not medical advice.
Thank you, Jody.
But you did represent the kind of nurse and leader that I hope to become. And now, years later, as I educate nurses on the nursing code of ethics, I see your book through a completely different lens. Your book is a memoir, but ethics is at the heart of every story. Advocacy, courage, dignity, autonomy, nurse-to-nurse respect, moral distress, leadership, and it is knowing when to speak, when to stay, when to leave, and when to stand firm. And that is why this conversation means so much to me. So Lisa, welcome to Nurses Out Loud.
Thank you, Jody. I really appreciate the opportunity. And I don't mean this in any way except pure pride. I'm so proud of what you've done in your journey and what you will do. It's just amazing how we met all those years ago, and here we are again. It really means so much to me. Thank you so much for this.
Yes, you're welcome. I mean, I remember you talk about a chapter in your book when you decided to leave, and I don't know why you left, but I just felt like I didn't have anybody to help back me up, after you left. And you probably don't even remember too much about me because I think it was only maybe 6 months or something that you and I worked together. But I respected you. You got along with everybody, but you were strong and you had standards. And it just was so amazing for me. And I'm just super happy to be able to share your book with others. I couldn't put it down. I'm not a reader. I have gotten dozens of books over the last 5 years, and your book I literally could not put down. So congratulations on that.
Thank you. It's been a really a labor of love for sure, pouring the stories out. It took a very little amount of time, relatively speaking, about 5 weeks, and the stories just came out. And several of the friends and colleagues who have bought the book asked me, did you take notes throughout your career? And I said, my goodness, no. Those stories are in my heart and then my mind. It was just a matter of pouring them out onto the pages. It just came out, and it felt great to be able to remember like it was yesterday, those stories. So it was a great time, a great experience for me as well.
Wow. Yeah. What made you decide to write The Heart Behind the Badge?
That's a great question, Jody. In today's world, my goal was to appeal to people, not necessarily nurses, but all people who have ever been a patient, who've ever wondered what nurses do, who've had a family member in to show what nurses do every day. Not just me, I'm one of millions of nurses, but what nurses do to help save lives. And for me, this book was an evolution of how I started as Lisa RN to my evolution of to become Dr. Caplan and then, of course, Dr. Swoop. That is what I wanted to show how someone who was humble in the beginning, certainly not knowing anything about nursing, to become someone now who is a nurse leader, who gets to lead an incredible team and watch nurses now that I have helped to train and to support and to mentor, help them save lives and support family. There's nothing more rewarding for sure.
Yes, like I said, I mean, you made such an impact on me and you didn't even know it, but the stories and the way you lay them out. I don't have the book in front of me now because I gave it to my future daughter-in-law, who's also a nurse. But there's many chapters, and they're only a couple of pages each. And the way that you were able to bring the stories in just a few hundred words. Was amazing.
I appreciate that. I really wanted to keep it, we always say keep it simple and keep it short and make sure that my message was conveyed. But I wanted it to appeal to people who maybe don't have all the clinical background or people who are new to nursing or thinking about becoming nurses so they could just get a taste of what it's like. You could write an entire book on one of the any one of those chapters if I got into, the great detail. But for me, it was to convey the emotion and to convey the joy, the heartbreak, the laughter, just the sense of the team and how nurses help each other. Not, as you said, sometimes there can be a negative aspect to nurses, the way they treat each other, but I want to kind of overcome that and rise above that to show the world what nurses do is imperative for our society.
Imperative, absolutely. I do love the way that when you talked about certain diagnostic testing or when you got a little bit more scientific, how you put in the images for people, just the common person to look at what you were actually talking about. It just was so cool to see that.
I appreciate that. I mean, I think that's really important so that several people who have written reviews and have gotten back to me that are not nurses have said, I understood every word you wrote. Even my 13-year-old grandson has read the book 4 times. He called me Tutu, which is the Hawaiian word for grandma. But he said, Tutu, I understood everything you wrote. And that made me feel so proud because that's what I wanted to appeal to many, for them to get a glimpse. So that made me really happy.
Yes, you did. So yeah, and a lot of people that listen to Nurses Out Loud are not just they're not nurses, they're patients. So they're wanting to get to know more about the nurse, and this book certainly does that. One of the things that I teach nurses is the Nursing Code of Ethics, and I believe it's one of the greatest professional documents ever written. I often correlated to the Bible. I say that the Bible guides the believer the way the code of nurses should guide the nurse. But many people were not taught it in nursing school. It's not a core curriculum. I don't know if your experience is different, but every time I ask nurses what the nursing code of ethics is, they always just list out the principles. Do no harm, they say. You're the patient advocate. And I say, yes, yeah, keep going. But many haven't heard of it. And, we're taught policies, protocols, charting, clicking the boxes and those kinds of things. But many nurses, we're not taught the moral foundation of the profession. And I think this book, and how many chapters is it? It's a lot.
It's around 35 chapters, I think, off the top of my head. And then there's them in memory. I would say around 35.
Right. And 35 chapters, about 150 pages. So it's a really quick read. I just kept thinking this is what the code looks like in real life. And so after looking back at the 40 years, do you think that you were practicing from that ethical framework, the Nursing Code of Ethics, or was it just more intrinsic for you?
That's a great question, Jody. For me, ethics and nursing is synonymous because as a nurse, you have a choice when you are taking care of a patient and something comes up which is morally distressing and ethically ambiguous or ambivalent. it's up to you as the nurse to, if you don't know specifically what ethical issue it is to look into it, find out, go above and beyond to try to reach the core of what's the right thing to do. It's
Mhm.
more than just checking the boxes. As a nurse, you can do that. You can become a nurse and spend your time with your back to your patient while you're doing their admission. You can click all the boxes. You can be
Mhm.
very efficient in your ways of delivering care, but you're missing so much of what patients and family members need. They don't understand what's happening. They don't know what they're supposed to do. And I know with my experience with the patient who was shot in his back, that I
Mhm.
was pretty new to nursing, and my nurse manager was amazing at guiding me to saying, you are the one who has to go to before the ethics committee and speak for this man who cannot speak for himself. Yes, I was terrified, but I did the right thing. And I looked in the eyes of his family members and I knew this is what I'm supposed to do now. And that was a real turning point for me to look beyond the obvious of what a patient needs to what a
Yeah.
patient should have to make their experience morally and ethically correct.
Yeah, that this is a 27-year-old that did not want to live paralyzed, right?
Yes,
That
yes.
really stuck out for me in the way that you had handled that. Now you're telling me that you were a newer nurse when this happened?
Pretty new. I would say within the first 5 years, maybe
Yeah.
6 years of my practice. So definitely pretty new. And all I knew is, well, when he was, before he went to the operating room, he was able to speak. And he asked me, what's wrong? Why can't I move? And I told him, you got shot. And he said, oh my gosh, am I going to get better? And I said, I don't know. And that's when he said, promise me you won't let me live like this. So there it was. He told me, I knew it, and no one else had heard him say that. So it was up to me. And having that information and not knowing what to do with it, I went to my manager, and
Mhm.
she was able to guide me through that. I'm so grateful that she was. To be in that position and have to deal with that, those things are stressful. But you have managers, you have supervisors and even more senior nurses that you trust that you can go to and you should go to not let things like that just blow away. I mean, this man needed me to speak for him.
Yeah, like, talk about that. What happened? You said that, he told you before he went into surgery, and was
Yes,
it his parents that they were deciding on, to keep him on life support? I mean, talk to us a little bit about that story
sure.
and
I mean, he was so young. He had gone to his ex-wife and she had a new partner and he was trying to run away. They had some sort of altercation and the man shot him in the back. So when he came in, it was very kind of an emergent. We have to take him to the operating room. The neurosurgeon wanted to try to decrease the swelling in the spinal cord to hopefully give him some of his movement. All he could do was shrug his shoulders and talk a little bit. His voice was very weak and quiet. But when his family, his brother and his mom came in, they had never talked about what happens if I get shot. What would I want to have done? It's not like an elderly patient who knows they don't want heroics. This was a young, vibrant man. So the brother and mom, after their initial shock and terror and crying, the brother said, "I have no idea what to do here." When he came back from surgery, he suffered spinal shock and an actual ischemia where there was enough blood flow to the spine. So he was going to be a quadriplegic on the ventilator for the rest of his life, not able to breathe on his own, not able to move. And when the brother said and the mother said that to me, I said, well, he told me before surgery. And they said, what do you mean? And I said, well, he wouldn't want any of this done. And they said, my God, will you tell the doctors? And I said, well, it's not that simple because if he doesn't have the breathing machine, the ventilator, he will die. And from there, the family, and I continued to take care of this patient for several days. And the family then asked for an ethics consult and for me to come and help them at an ethics meeting to discuss taking him off the ventilator. That wasn't
Mhm.
done then often. That
Yeah.
was a very new concept of palliative care then. So it was definitely strange territory for me.
So the family want to honor his wishes. What was the
Yes.
medical team saying? Were they trying to fight back on that?
It
That
was very,
prompted the ethics review?
yeah, it was the trauma physician and the neurosurgeon both were not comfortable with kind of making this decision. We tried to wean his sedation a bit so that they could ask him, the question, do you want all this to continue? What do you want? But every time they would lower the sedation, he would start coughing and the ventilator would alarm, and they weren't able to remove the sedation enough to be able to evaluate what he had wanted. So the ethics council came up. The doctors said that they would honor what the patient told me, so long as I would represent the patient with his brother and mother all in agreement. So I appreciated the relationship I had with those physicians. We were really excellent collaborative colleagues. They respected me and I respected them. It was really wonderful of
Yeah,
them.
that's great. Tell the listeners a little bit about your experience as a nurse.
So I started off in almost 40 years ago in a step down unit after nursing school. And after 6 months, I wanted to go to the ICU just because when I would be working, my patients would go bad, quote unquote, where they would have some sort of clinical deterioration. They would require ICU level of care. And I was just fascinated by the critical care environment. So we had to wait 6 months. And after 6 months, I transferred to critical care. And after about a year of crying every day with fear and frustration and worry, I suddenly started to really understand what the critical care nurse's role is and how I can use my skills, my commitment to patient care excellence to really help patients at their most vulnerable point. I
Mhm.
loved it. And I stayed in critical care for 25 years, 30 years. And then I kind of led into leadership opportunities, being a charge nurse. And I remember the first time they wanted me to be in charge. I said, "Oh no, 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 no! I'm not charge nurse type. I am, I am not a tough. I don't yell, and I'm not a tough cookie. And I will tell you what is the truth. I'm not going to say what you want to hear. So if you want someone who just says yes, 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 and I'm not the person." And my manager said that is exactly why you're going to be a great leader, because you're willing to stand up and tell the truth. And I said, all right, I'll give it a go. And sure
Mhm.
enough, a lot of times I did have to stand up for my nurses and I demanded respect for them. Patients were not going to speak to them harshly or abusively. I don't tolerate that. And
Mhm.
from there, leadership became my focus. And I went back and got my master's and then my doctorate with the emphasis on leadership. And it's been an amazing journey for me.
Yeah, yes. There was also a story in the book, The Patient in the Heart Block, and you wrote a moment where you had to push back and you actually defied a doctor's order right in front of you because of what you were seeing clinically. I can't even tell you how much that meant to me to see, because I think so many nurses, they think that policy and protocol that we work for doctors. We're very much very independent of doctors, but to have the courage and the training to see what you were seeing on that monitor, what gave you trust on that assessment? And maybe tell us a little bit about that story.
Sure. So this actually happened twice, but the one time was when I was working in the hospital and it was a physician who was in training. And, I had the utmost respect for physicians. They would come to me as the charge nurse in their first days and they would ask me, what can I do to be successful? And I'd say, listen to what your nurse tells you. When you come in the morning, ask the nurse, what does your patient need today? And that nurse will fill you in, get your pen ready and start writing, because he or she will tell you everything your patient needs. If you listen to that nurse, your patient will have the best chance. So I was helping a particular surgeon float a Swan-Ganz catheter, which is a catheter that's used to measure pressures in the heart. And it is not an innocuous thing. It can cause complications. When the Swan-Ganz goes through the heart, actually, it can cause arrhythmias and it can even cause a heart block where there's a disconnect between the upper part and the lower part of the heart, which if untreated, the patient will not make it. So I was helping this physician with the Swan. And nurses, do have an active part in that, where we help to assist to float the swan into the correct part of the pulmonary artery. And I looked up at the monitor, the alarm went off, and the patient was having wide complexes across the screen at a very low rate. Maybe the heart rate was 40, and usually it should be 70 to 90. And I said, oh my goodness, the patient just went into complete heart block. Stop what you're doing, and we need to get a cardiologist to put a pacemaker. And the resident surgeon said, no, no, this is not complete heart block. This patient is having ectopy, meaning abnormal beats. And he wanted me to give the patient a medicine called lidocaine to stop the heart from throwing those beats. And I said, doctor, if I do that, the patient's going to die. We're not going to give lidocaine. This patient needs a pacemaker. And he said, I want to talk to the charge nurse. She'll give the meds. And I said, well, I'm the charge nurse. And I'm telling you, that is not going to happen. No one is going to come in this room and give this medicine to my patient. So he was mad, but he called the attending. The attending spoke to me and said, what's going on there? He didn't want to talk to the resident. He wanted to talk to me. He and I were, Dr. Nick is his name. He and I also were wonderful colleagues. I told him, and he said, thank you, put the resident on the phone, and he told the resident, you do exactly what this nurse tells you. So the cardiologist came, looked at the monitor, said the patient's in complete heart block. We put a pacemaker in, and as we put the pacemaker in, the patient's heart stopped. So the pacemaker was just in time to
Wow.
save the patient. But then the next day, the attending, Dr. Nick, was there with the resident, and he said to the resident, you apologize to this nurse, and the resident did. And I told the resident, I'm not here to argue with you. I'm here for my patient. Do not ever become so aggressive. Let's talk through things. We're on the same team. I have great respect for you, but please don't question the nurses here. We know what we're talking about.
Yeah. And when I go back to my time in the trauma center with you, the nurses at that time, I think the average length of stay that people were on the job was greater than 10 years.
Yes.
They were just amazing. I always describe them as a well-oiled machine. You guys just blew me away. And I learned so much from them, what kind of nurse I wanted to be and what kind of nurse I didn't,
Sure.
on both ends of it. But what gave you the courage to trust that assessment, especially with the doctor giving you the orders at the bedside? Like, how did you train with knowing the cardiac monitoring? I mean, I think a lot of us, when we work in critical care, like I'm in the ER, I spend some time in the ICU, but still nurses, they reading a rhythm monitor is still kind of, they don't know it well enough to tell the doctor that. At least this is what I'm seeing
I see.
in
Yeah, for
today's
me,
nursing.
sure. For me, when I started in critical care, I knew that I wasn't going to fit in with the other critical care nurses because I wasn't tough and I didn't have the confidence. So I decided I'm going to start reading and learning about diseases, learning about the heart rhythm, learning about the medications so that I can build my confidence. And through all those years of studying it, learning it, reviewing it, then I started teaching heart rhythms, heart recognition, treatment of different rhythms. That's how I became confident. And then those same nurses that, back in the day, Jody, when you were a new ICU nurse, the feeling was, they eat their young, the
Yeah.
older nurses, ICU nurses. And after a while, people started leaving me alone, and they would ask me, Lisa, come in my room and look at this. What do you think this heart rhythm is? What do you think we should do about this? What do you think about that? Then I thought, oh, I see. Now I'm good enough that they'll let me come in and be able to support them. So it just became kind of my obsession to keep learning heart rhythms, because if the patient would have some clinical deterioration, when I would call the physician, they want to know what's going on, what's the rhythm, what did you do, what did you send for lab work. So I felt it was my responsibility to really understand rhythms, to be able to teach and to be able to help my patients through a crisis.
Hmm. Did you ever get backlash for speaking up?
No, no. And I think it's because the attending physicians at the hospital where I worked were very nurse forward. They were very focused on the nursing team, and what the nurses were doing were also very highly respected. Conversely, if you did something that the physician was not happy with, they would let you know. And
Hmm.
you only would do that once. But they didn't come in and scream and yell. They would come in and say, I need to talk to you about last night. You were here and you said such and such about this patient. They really would try to teach us as well about clinical assessment, about when to call the doctor, because you have to have a lot of courage to call a neurosurgeon at 2 a.m. to say, I need you to get in here because this patient isn't doing well. So we had to build the confidence and that knowledge base to be able to say, doctor, I need you to come in. This patient is not doing well. And the doctors would come in without a word. They'd say, I'll be in
Yeah.
10, 15 minutes. So that was a great trusting relationship that's integral in hospitals between physicians and nurses. And I like those shows such as The Pit that depict that collaborative relationship between physician and nurse, and how important the nurse is to help the physician and to help the patient, which is at the center of all of our decisions.
Yeah, absolutely. I know when I became a nurse, I went to the med surg unit for a year before I went down to the ED. But when I went for med surg, I knew that the best way for me to do my assessments was to round with doctors. And I very quickly gained the respect of the doctors because I wanted to be in there for two reasons. One, to understand what their plan of care would be for that patient that day. And number two was to assess the patient's learning or receptiveness. Did they understand what that physician just said? Because if I could get those two things, honed in for the day, that would limit me from having to call the doctor. That would limit the patient's anxiety about what their day is going to look like. I wouldn't have to call the doctor to ask him, hey, why did you order this and that? And then I understood, and then I learned. So I guess it's three ways. Then I learned what their thought processes were, and I learned so much about that. What would you, and having said that, I also know that we need to trust our gut, right? And when something isn't right, to speak up. Or when you see that patient who is taking in this information from the doctor, I would keep the doctor in the room because I would look at the patient and say, I don't think they're really understanding what he's saying. And I would ask the patient, do you understand what they just told you? And most of the time they would say yes. And then I would say, okay, well, tell me what they just said. And it would keep the doctor in at the bedside a little bit longer, but they also respected that because I never really had to call them. You know what I'm saying?
Yes. Yeah, that's excellent. The more you can involve yourself with physicians, and the physicians will really tend to, as you say, really develop respect for you and really develop the sense of that you're really here to not bother them or question them. You're there to join them in the fight for this patient's life. And
Mhm.
that's a wonderful feeling when you know this physician really trusts me. That is exactly what you want to achieve. And for me, when I wrote about a young man who'd been hit in the head with a baseball, and it was my patient, and I hadn't ever taken care of someone who he had an epidural hematoma. I'd never taken care of someone like that. And I met the neurosurgeon who was on the telephone and actually put my hands on the neurosurgeon to get him to come into the room when the patient's pupil became large. And I knew that the patient was in a terrible crisis and
Mhm.
needed a surgery or he was going to die. So that was not my favorite way to meet a surgeon. But afterwards, the surgeon raced the patient to the operating room. And when he came back, he came to find me to introduce himself to me, to apologize that he didn't respond to me when I was calling his name. So, in that sense, it was certainly a great way to form a relationship. And this neurosurgeon and I were close for the 18 years that I worked at this first hospital. He was a
Mhm.
wonderful colleague to have, and we spent a lot of time together helping patients that he was caring for or we were caring for together.
Yeah, I love that. I mean, I tell people being an advocate is not being rebellious.
No.
In the code, our code of ethics actually makes it clear that we have the authority, the responsibility, and the accountability for our own practice. And we're not just task doers, we're licensed professionals with a duty to the patient and we work alongside doctors.
Yes.
we don't work for them. Unless you're in a, family practice or something, but when you're in a hospital situation, you own your own practice basically. And I think throughout this book, you're able to articulate that and your assessments very well. I just it was so good. There was another moment that really stuck with me. Was there was a part in the book where you mentioned not wanting to take the COVID shot. And I'm not sure if you know much about what I've gone through in the last 5 years, but this is where I want to pause a little bit, because this is where my advocacy really began. And ultimately, when I became a whistleblower, I just realized that I had a lot of issues with the way where our standards of care changed and all of that. But then when the shock came out, I realized that we weren't really documenting any safety signals to VAERS. I think the National Council of the State Board of Nursing says from 21 to 22, more than 130,000 nurses left the profession, and, citing moral injury or their own autonomy. Can you talk to us a little bit about that?
Sure. I mean, that was a very, very difficult time for all of our society. For me personally, I had moved to Pennsylvania, and I was working in a hospital, and I loved the people, and I loved the nurses I was working with. I was living right by my oldest son, my grandson, my daughter-in-law, literally less than 5 minutes away. It was fantastic. He never had left a job unless I was promoted, but this was a circumstance when all of the vaccine came through. My dad died of ALS, and ALS is a disease where there is an immune response, an over response to that causes the neurons to become destroyed. It's inflammatory response in some way. And the COVID shot is exactly that, produces an inflammatory response. So my physician said, do not get the vaccine. At the hospital I worked, that you had to either have a medical excuse or you had to fill out a religious exemption. And I didn't really want to broadcast the fact that my dad had died of ALS because no one knows about ALS in terms of there is some potential genetic, but no one's really sure. So I filled out a religious exemption and it was denied. So I had another job at the hospital I'm working at, currently working part time. I talked to my manager there and she said, oh my goodness, we'll take you full time here. But to work at that job, I was going to have to move. I was going to have to sell my house. I was going to have to leave this hospital. And here I am, a doctoral nurse with, at that time, 30 years experience. The hospital let me walk out. I waited till the very last day. And then I had sent my letter of resignation in. Someone from Human Resources found me and she said, I had no idea your dad died of ALS. I said, well, what difference does that make? She said, well, you can stay at the hospital here and you just have to be tested once a week at your expense. And I said, well, what sense does that make if I'm not sick? Why would I need to pay to be tested once a week? I said, I'm sorry, but I'm going to go to a different hospital. And came to the hospital I'm currently working. It was heartbreaking for me and for my staff, but Jody, I had to stay true to my convictions. And my mom said too, well, if you get ALS, maybe you could come. I said, Mom, it's a fatal disease. I can't take the chance. So I respectfully had to leave and come to my new hospital. It was a very, very difficult time for me, for sure.
Very difficult. Yes. I think, but again, I think you represent what it means to not only honor your patient's autonomy, but your own, and not to compromise. I mean, for me, I surely didn't want to stand out and become, a whistleblower on all of this. I didn't, but it really happened at a time where I was seeing injuries from it and actually going to the bedside with the doctor and letting them do their assessment on patients that say had Bell's palsy, right? And then asking them, hey, did you take the COVID shot? Yeah, yesterday, and then the doctor walked away out of there and said, oh, I'm so sorry. I should have asked that. I said, that's a problem. Nobody is. Nobody's asking this. And then I had another patient who was in his early 30s who at 2 weeks, or no, he took the second shot. And 3 days after that, he came into the hospital with myocarditis, pericarditis, and congestive heart failure. And at that time is when I asked the doctors, like, hey, we think it's a shot here? And the one doctor, stood up and was like, yeah, nobody's asking about it. So anyway, without going into all of that, those were things that were happening. And for you, I think the coercion and the fear, the division among nurses, everything became so political, and the pressure from the systems. I mean, here you are, a nurse 30 years plus with critical care experience, management experience, and they were willing to let you go. And and they did.
Yeah. Yeah. And I mean, looking back with what I'm doing now in the hospital I work, it's a fantastic hospital. I feel our team is amazing. I have a very lovely job where I get to have a lot of responsibility when I'm there as an administrative supervisor. It's a great job, and I'm so glad that I moved into it. But
Yeah.
as you say, it was a very, very difficult time. And the thing about nurses is,
if you are a nurse that is fed up with the sick care model, I have a solution for you. My name is Melissa Schreidfatter, and I am the owner and founder of the Functional Nurse Academy. FNA is the most comprehensive functional medicine training program on the market, specifically tailored to nurses. It is self-paced and equips LPNs, RNs, and nurse practitioners to practice functional medicine, address the root causes of dysfunction, and start their independent functional medicine practices. At FNA, you will learn how to order labs, functional health reports, create customized wellness plans, package and price your services, and even how to market your brand effectively. Graduates earn 90 nursing CEUs, and then they qualify for multiple board certification titles. They also will have access to our exclusive tools, such as our Functional Nurse Toolkit, our social media and marketing kit. And I don't want to just train you and send you on your way. So you also will get access to me each month via the Functional Nurse Academy monthly mentorship program, where you will be able to attend a live class with me each month. So say goodbye to sick care and start your dream career as a functional medicine nurse. Enroll today at functionalnurseacademy.com.
when someone comes in and needs help, we don't know what their political affiliation, we don't know anything about them. All we know is this is a person who needs help. And I think if you ask any of the 6 million, 7 million nurses in this world, why did you become a nurse? They don't talk about the politics. It doesn't matter. It matters. There's a person in front of me who needs help, and I want to help this person to the best of my ability. And that's why you become a nurse. And when politics gets into it, and all of the other things that happened with COVID, what you have to have the shot or you get, that whole thing seems surreal to me.
Mm-hmm.
Very morally distressing, as you described. And I don't know if the nurses that left, that makes me sad. I know several nurses couldn't take that any longer and decided just to retire or to get out of nursing. What a shame, Jody. What a shame.
100%. It was such a shame because to me, I thought, well, looking at it at the time, I realized that they were trying to get the dissenting critical thinker out because that's who left. The nurses, and then you had all these new grad nurses that became COVID nurses immediately because it really didn't take much to care for a COVID patient. Honestly, we isolated them, we weren't even going in the rooms. Doctors were getting the report from nurses and then charting report received from nurse due to lessening COVID exposure. It's like so many things had happened. I remember one time a cardiologist got called in and he came in and he looked at the patient and he was at the window of the ICU door or of the ER door. And he said, "Who is the doctor on this patient?" patient. Where is he? And he called him and he said, look, he's in congestive heart failure. I can see his jugular vein distended from here. This is not COVID. And he just went off on him, because again, people were not assessing it. But do you think that changed the profession?
I mean, I know during that time, most heartbreaking of all was the patients and the families not being able to say goodbye or see each other, or patients were so isolated. And what was interesting for me is that's when I was finishing my dissertation my thesis for my doctorate. And my doctorate was basically to use a communication tool called AIDIT, where you acknowledge, introduce, duration, explain, and thank, using that communication tool to help increase patient satisfaction. So when COVID hit, I called my advisor at Jacksonville University and I said, Dr. Kunkel, how am I going to do this when I can't talk to the nurses can't talk to the patients? She said, well, you'll figure it out. That's what you do when you get your doctorate. So it was an incredible challenge to try to still for the nurses to make that personal connection. But I'm grateful that I had the opportunity because I would go to the nurses. We would have on our, PPE and we would still talk and they would still go in the rooms and talk to the patients. And I was able to achieve positive improvement in those satisfaction scores, even though it was a COVID environment with the limited exposure. Whether COVID changed nursing profession, I think that's a good question. For me, it just made me really sad that it became not about the patient at the center. It became about something else. Political, conspiracy, Democrat versus Republican, all things that are for some people, that's the most important thing to them, but that's not what nurses are all about. That has nothing to do with nursing. Nurses are wanting to help take care of patients.
Yeah, it did become politically divisive. I talk about in my book, the nurse and doctor. There was a charge nurse, and I was house supervisor that night, and the charge nurse and the ER and the doctor, ER doctor, they were talking to me and they said, Jody, I know you don't believe in masks and you don't believe in the shot. Do you think that if you got COVID, we should have to treat you? And I just was blown away that, number one, those words even came out of your mouth in public. And that, that you had the heart to say this. And so many people, safe and effective. And I was just like, how can you say that? Just because it's brand new technology.
Right.
And then, for the people that had worked in those COVID units for over a year, the mandate came down on all of hospital workers. It started at Houston Methodist in Texas that you're either going to take the shot or leave. And there's a National Council State Board of Nursing in 2024, the National Nursing Workforce Study says 40 of nurses indicated an intent to leave the workforce by 2029. That is potentially 1.6 million nurses.
That could be devastating for patients and for nursing units. For the nurses themselves, imagine a nurse whose ratio used to be a 4-to-1, and now they have to take care of 6 or 7 patients. Things will get missed, and patients will suffer, and nurses will become more and more stressed and dissatisfied, which will perpetuate more nurses leaving. I mean, it is definitely a call to, and for me with this book, my call is to help to try to inspire nurses, nursing students, those who are thinking of becoming nurses, to go ahead and take the leap and experience the joy of nursing, for the good, the bad, all of it, because the patients deserve to have that care. And nurses, when you are in it, I've been in it almost 40 years, I still love what I do. And the moments I get to still connect with the patient. Last night when I was at work, there was a lady who went into VTAC where her heart was racing and she was awake, but she was scared. And all the people around her were talking about her heart. So I went in and I offered her a warm blanket. I held her hand. I sat with her, reassured her. That was what I was supposed to be doing to bring her comfort. She smiled at me, and I knew that I helped her to feel like, I see you and I care for you. And I told her, you're going to be fine. All these people here are to help you. And I know it's scary, but these are all experts in their field. She's like, okay, thanks for telling me. I thought I was dying. I said, oh, no. You're not dying.
Mm.
You just have everyone's attention now." And she giggled, and it was a very lovely interaction. And I'm glad I walked in there to visit with her for a minute.
Yeah, that reminds me of Lawrence in your book, the 18-year-old gunshot patient. Yeah, do you want to talk about Lawrence?
Sure. So that was incredible. In the ICU where I worked, we would go down and respond to when the trauma buzzer would go off. One of our nurses would go down. So I happened to be the one who responded, and I went down, and there was many, many doctors or people, nurses, different people down there. And in the center of them all was a young gentleman, African American black gentleman, lying on the table, and he had his head turned away from me, and I could see a bullet hole here in his neck, and that's a very significant injury. In the zone 1 is what it's called, of a neck injury. They're mostly fatal, and he didn't move. He just was lying there, and I thought, oh my goodness, he looks like he might be dead. So no one was talking to him. So I went over and I said, "Hello, how are you doing?" He turned his head and looked at me, and I said, "Hi, my name's Lisa. How are you doing?" And he reached his hands up to me and he said, "Am I going to die?" And I said, "Oh no, you're fine. This happens all the time. You're going to be fine." And I turned to the doctors and I said, "Let's go to the operating room." And everyone started running around, and we raced him up to the operating room, and he went to the OR, and all he had was a small nick to his lung that caused his lung to
Mhm.
collapse. So he came back to the ICU. I was actually his nurse, and he came back without the breathing machine. He just had a tube in his chest, very small tube that was going to be resolved in the next few days. And he looked at me and he said, "I remember you. You said I was going to make it." And I said, "Well," he said, "did you really think that?" I said, "I don't know. That was, you had a really significant injury." But I said, "Lauren, there's a reason you survived this. You need to find out why now. You're on this earth. Find out something now about your life you can do that's positive and helpful, because you live for a reason." And he cried, and then he said he would. I don't know what happened to him, but I
Mhm.
was so grateful that I was there at that moment to first engage with him as someone lying here on this table who's terrified. And when I told him this happened all the time, I mean, it doesn't. But in that moment, I wanted him to not be afraid.
Yeah, yeah. What good would it have made to say, "No, this is actually the worst gunshot that you could have gotten"? It
Right,
doesn't, right?
right. I wanted to try to cushion that just a little bit for him, for sure.
Yes, absolutely. Let's close out with kind of a funny story that I really liked. And I'm going to say that this happened in the hospital that you and I both worked at, the naked running man.
Yeah. Oh my gosh, Jody. And I've heard from several of our nursing colleagues who have Amy and Shirley and Don,
Uh,
and Polly, who all were there that night, and Nima as well. So I was at my desk, and the other house supervisor that night, Deb, she happened to be outside on a smoke break. And I was in the office, and I heard what sounded like a woman screaming. So I jumped up and I ran to the source of the screaming, and it was two male nurses in the room. I don't know who screamed that high pitched scream, but the patient had pulled out his breathing tube, pulled apart his catheter, draining his urine, and he was naked, standing on top of his bed with restraints still on his wrist. And he jumped over the two nurses and started running down the hall. And I screamed, get away, because I didn't want anyone to get exposed, because there was urine coming out of the tube that was still inside of him. There was blood on the floor. So he started running down the hall. And because there was moisture there, he slid down the hall and hit the elevator, ran down the back hall, ran down the back stairs. I ran after him. We ran all the way down the stairs. He ran past Deb, who was the other supervisor, and she was out there smoking. She watched him run. Then I came behind and I said, "Hey, Deb." She said, "Hey, Lisa." And she took a puff of her cigarette. And the man kept running. I kept running after him. He ran and ran and ran. And we were in Scottsdale. We ended up in Tempe with me following behind him. And then he hid behind a tree, but you could still see the white restraint dangling there off of his wrist. So I stopped running and was catching my breath. And another PCT, Charisse, had caught up with me, and she was standing there with me. And then the police came, security came, and I said, "He's there behind the tree." So they screamed, "We see you behind the tree." And I thought, great. So the man took off and ran and jumped over this huge, probably 15-foot wall and disappeared. And the police officers climbed the wall after him. And I thought, no, no, no. I walked around the block to find the entrance to where this apartment complex was. When I got to where the patient was, he was lying on the ground. The police were around him. The police said, "Is this the patient?" And I said, "How many other naked men with cuffs around their wrists do you think we'll see at 2 o'clock in the morning?" So they took the man back into their squad car, and no one gave me a ride, so I walked back. Then Nima, the supervisor, called me and she said, "Where are you right now?" And I said, "I don't know." And I said to the officer, "Where are we?" And he says, "You're in Tempe." And I said, "Nima, I'm in Tempe." She said, "Get your butt," she didn't say but, "back to this hospital right away." So I ran back. And I remember when I walked into the ICU, all the nurses stopped and turned and gave me a hand, and I did take a bow. But we were able to catch him, and he was there because he had swallowed several heroin balloons. So he had those in his belly, which is a very potentially fatal situation if one of those burst. So he had to stay in our hospital and was restrained, this time with stronger restraints, sedated, until he was able to be successfully taken to prison.
Yeah, that's just such a story. There's so many. I can't believe that we're almost up at our hour. I
Oh
I
my
have to
goodness,
have
that
you
flew by.
I know. I have to have you back on because there's so much that I do want to talk to you and get your opinion on how we can help nurses. Maybe do a show on the burnout and the bedside, the workplace violence that a lot of nurses are talking about the reasons why they're leaving. So guys,
Yes.
send me a note. Nurses or an email, nursesoutloud@gmail.com. Whatever you're watching this on, please feel free to comment. There's also going to be a Substack article at for Nurses Out Loud on this. So I'll gather those comments and everything, Lisa, and I'll have you back on because you're just such a breath of fresh air to me, honestly.
Thank you, Jody.
I love, all the letters behind your name, all the years of experience, and you still are standing true to yourself and to the code, really.
Yes, that's what it's all about. That's what it's all about. Thank you, Jody. I really enjoyed our time as well.
Yeah. So the heart behind the badge, guys, you can get that on Amazon. Just type that in, the heart behind the badge. And until next time, friends, be safe, be well, and God bless. Thank you for listening to Nurses Out Loud. Nurses are called by our code of ethics to keep learning, do the research, and lead with moral courage and integrity, especially as healthcare changes. Keep doing the next right thing, especially when it's hard. If this show resonated with you, please like, share, and follow. It boosts us up in the algorithm so more people can find us. Until next time, friends, be safe, be well, and God bless. And if this episode offers continuing education credit, check the show notes for the learning objectives, disclosures, and exactly how to earn your certificate.